right. Well, to keep us on schedule, it's 10 a.m. So welcome everyone. I'm Anna DePompolo. So I am excited to be here. I am your welcomer and we'll set the stage for the day. So welcome to the Pediatric Surge Workshop this morning. Let's see if I can advance my screen's technology here. Okay. So thank you all for joining today. We wanted to kind of set the scene for what we're going to talk about. So specifically why this topic matters. So a quarter of our population is pediatrics. And so in today's world, we're seeing increasing threats to children, and that is in many different realms, including infection, man-made or inflicted, natural disasters, and other catastrophes. And we do know that the pediatric population has certain vulnerable sets of things that we need to think about for providing care. And so we want to kind of make sure we're addressing those today during this talk. So the goals of this presentation are to discuss pediatric surge plans. So evaluating what you might need to be considering for your institution or agency. We want to discuss the roles that would be involved in a surge plan, and then kind of review different surge scenarios, including non-trauma aspects with pediatric care, and then also show some resources that are available to you and your agencies as you're planning and evaluating your current pediatric surge plans. In addition, we want to highlight some of, again, the aspects that are involved with caring for pediatric patients, both in trauma and non-trauma scenarios. This has definitely been a collaborative effort. There are 3 organizations that have been most involved with kind of developing this presentation for you. So there's Region 5 for Kids, the Minnesota Department of Health, and then Emergency Medical Services for Children in Minnesota. Yay. So the first one I want to just kind of highlight who these organizations are. This is obviously a very high level points. These organizations do much more than these very high pointed aspects. So I just want to make sure that I acknowledge that and the work that these organizations are doing. So Region 5 for Kids, this is led through Rainbow Babies and Children's Hospital in Cleveland. It's also in association with 9 other hospitals, pediatric hospitals in the following states of Ohio, Michigan, Illinois, Indiana, Wisconsin, and then Minnesota. Their overall mission is to develop the best practices around disaster preparedness, specifically for pediatric care. And they want to really build on existing foundations in pediatric clinical care and emergency response. And this effort is a coordinated effort both on the local, state, and regional levels. The Minnesota Department of Health, obviously their mission is to protect and maintain and improve the health of all Minnesotans. And they actually have some really great resources specific to pediatric surge plans that we want to make sure you're aware of. In addition, they do highlight, the unique needs that are involved with pediatric care. They have planning and toolkits, and so we'll kind of talk through some of that throughout today. And they also do a coordinated care within the state with their healthcare coalitions, the Minnesota hospitals, and emergency medical services. And then emergency medical services for children in Minnesota. So the mission is to ensure that all pediatric patients receive the best care possible, no matter where they are presenting with their emergency. And this also is a collaborative effort working with both hospitals and EMS agencies, and provides significant resources and education to help with disaster and pediatric readiness overall. So the agenda today is on the screen here. We're going to start off with Dr. Paula Kocken from Children's Minnesota discussing the pediatric surge plan. We'll then have Dr. Dingeldein from Rainbow Babies in Cleveland talking about pediatric trauma surge. And then we'll take a brief break for about 5 minutes. And then Dr. Saydi Chahla from Children's of Minnesota will review some pediatric case studies, again, kind of highlighting some specific thoughts when caring for pediatric patients. And then Alex Waterman from the Minnesota Department of Health will also provide some information on pediatric surge plans through the Minnesota Department of Health. We'll wrap up. We do want to make sure there is CME and CEUs available for physicians, nursing, and EMS agencies and agents that are here today. So we will talk a little bit about how to go about getting those credits at the end of the talk, just because with the 3 different disciplines, there's some different options of how to acquire that. So I'm going to hand this over to Dr. Paula Kocken, and thank you all for being here. We're very excited that you're here and interested in improving pediatric care.
Well, welcome. As Anna said, we want to go through some of our stuff regarding pediatric surge. And this is, we'll stop sharing. You want to continue? I want to continue. So let's go with this. Sorry, working through the details of the sharing. There we go. And let me get, there we go. All right, well, hope everybody can see the first page of the talk. As Anna DePompolo said, I'm Paula Kocken. I am the past pediatric manager for emergency medical services for children. Dr. DePompolo is the current manager, and I've been working with pediatric preparedness in the state of Minnesota for about 25 years. And so we're going to talk about a lot of topics and just touch on the topics and give you resources on how you can best manage a pediatric surge, both medical and traumatic. And so my talk is primarily about the plan and have you got a plan? So we'll go on with this. So the objectives of this talk are to primarily make you a little bit more aware of a pediatric surge plan that already exists in your facility or in your coalition. And then to understand that you might need to do some tweaks for it and do some alterations to make it better. Talk about using the plan as to what are the key areas and roles that you want to pay attention to with your plan during a pediatric medical surge. And then some of the unique aspects that children present with a pediatric surge. So things that you really want to be aware of when you have a large volume of patients. So to begin with, I'd like to talk about the definition of what a surge is for with pediatrics. And the deal is that it is whenever there are too many patients for your hospital or your coalition to take care of with the normal personnel, equipment, or space. So whenever it outpaces it, and it can be as few as 3 patients that come in the middle of the night, or as many as maybe 100 that present suddenly to a large hospital. Now, all of you, if you think back to May and April and March of this year, we had a large volume of pediatric medically ill patients coming into our hospitals that were mostly little sick children. And it was mostly due to the RSV, influenza, COVID combination of illnesses. And so that would be a good example of what a pediatric medical surge would be. Other examples are a little bit more mundane, and that would be things like poisoning, say at a YMCA swim meet where their ventilation was not functional, and you've got too much carbon monoxide going on, and you have a large volume of patients, even like 8 or 10 children having problems and presenting to a small hospital. That would be another medical surge. And then if you think back to the train derailment in Ohio back in the springtime as well, that could have caused a chemical poisoning surge of children, especially children, because they are, they're living closer to the ground where the heavier chemicals can locate, and also they have a faster respiratory rate. So they would be at high risk of getting poisoned by that. So these are some of the things. When we think of a surge of patients, we usually think it's a traumatic episode where a structure broke apart. But it's actually could be any of these other 3. So how do you handle it? Well, the coalitions and the hospitals all have to have surge plans in their emergency preparedness files. However, the important thing is knowing where they are and how to use them. a lot of the plans are kept on online computer sites. And I advocate for having at least a few of these plans printed out and handy, because you never know if you have a power outage, and that would be part of the problem. So having a few hard copies available, and then having them very simple and available to everybody so they know what their roles are. Most of these acute surges, like the poisonings and such, happen during the nighttime hours or the evening hours when administrative people are not around. And it's important that everyone knows how to access the plans and how to trigger the episode, activate, and then call in help. Most of the hospitals and areas, small clinics, have a hospital incident command or an incident command that they can set up. And so it's wise to go ahead and get that incident command set up as soon as possible. However, this always takes a finite amount of time to establish it. And so the ER or the central location of the hospital needs to know what to do until help arrives. And so that is what your surge plan should involve as well. It should have an ability to take care of the patients until the incident command sets up. So some of the key ways of helping your plan out are listed here. So the last talk of the day is going to be Alex Waterman talking about the Minnesota Department of Health website. And this is a very nice website with stuff that's really specific to the state of Minnesota. So using that to help you. Also, the Assistance Center at Asper Tracy has very good written documents on how to handle a surge document. And so you can use that to help fine tune your Peds surge plan. And then finally, just recently, within the last 2 months, the group RAPM, which is the similar group as to our FEMA 5 for kids, but on the West Coast, they produced a playbook, which is a how-to guide on improving your surge plan. And the nice part about this document is that you can go through and say you have a question about reunification center. You can go to that segment and it will jump you in a hyperlink right to the information that they have all prepared on how to set up a reunification center and what sort of things you need and how to do it. So this just came out, as I said, within the last couple months, and it is a very good resource to us for using it to improve the surge plans. So getting down to brass tacks on your disaster, your surge of medical patients, you need to be able to know when to trigger it. And as I said, sometimes it can be 10 patients, 20 or 30, but on a night shift, it could be 5 or even 3. And then take into account, is it the volume that's your problem, or is it the complexity of the patient that's your problem? And that might also push you to starting your plan. Another is that if you're experiencing maybe 3 to 5 patients of very sick respiratory illness kids, and you say, okay, well, I just need to ship them to the bigger hospital, to the pediatric hospital or to the referral hospital, be aware that they're experiencing the same thing. And so they may not be able to accept your patient right away. So that might be another reason for activating your surge plan. Alternatively, you can also, instead of transferring patients out, you might be able to trigger your surge plan and then set up the ability to maintain a patient for a period of time. And by knowing who to call for help, setting up the incident command, and then also contacting ICUs, pediatric ICUs or adult ICUs for help as to how to manage a patient until you can transfer, are possible options for this. So the key locations and roles that we need to set up for in a surge are, the main thing is the front door, how you're going to handle the patients coming in either through the ED or even your front door itself. setting up a family reunification area, and then how do you handle unaccompanied minors and minimally injured patients. So with the front door, you're going to be talking about how are you going to triage them. Do you need to use a regular trauma triage system like Jumpstart or SALT, and knowing where that equipment and stuff is handy for handling them is important. How are you going to track the patients? If they're coming in at 3 to 5 every 10 minutes, you won't be able to track them their normal way because it takes time. So do you need to go to paper, or how are you going to keep track of where they're going? And then finally, as I stated, with the transferring of patients to another hospital, you might be concerned about whether you can transfer patients out right away. And maybe you need to determine who's the illest, who's the most ill. I don't know if that's a real word, illest, but who is the most ill, and transfer them first, or hold back until you have an assessment on who you're going to send out. Because especially if you're out in the outstate areas, you have limited number of ambulances that you can free up to transfer a patient, and limited number of helicopters to transfer. So even doing a triage on the transfer is important. Family reunification center is a very important area in a surge, especially a very fast acting surge like a poisoning, where you have many children and they are not accompanied by their caregivers. So the AAP has a toolkit on setting up that, but you'll need to make sure it's in a separate area from the ER, because everyone's going to go to the ER and they won't be able to process them that quickly. So if you can get them all to one site that's separate, and then send them to their children in space afterwards, that'll work. And then the other thing is that the unaccompanied minors and minimally injured patients will also be going through the ED, and you'll need to get them someplace else so that the ED can take care of the sick patients. And so having an area that is separate from the ER and separate from the family reunification area to put these unaccompanied minors. And the deal with those are that you've got a lot of kids that need to be monitored, so you have to have caregivers handy to watch them. So it gets very complicated, but these 3 areas set up right off the bang are the wisest. And then who is going to handle it? So you need to make sure you've got your incident commander set up. You need to get your communication center, and then figure out who you're going to call for help. Initially, the incident commander will possibly be either the charge nurse or the physician in charge in the ER, and just to set things up and get things going until the hospital incident command can be set up. And then how are you going to communicate with them? If I know many of you lived through the bridge collapse in Minneapolis, and at that time the cell phone towers got saturated with calls during that, and our cell phones didn't work. And so we had to realize that we needed to switch back to the 800 megahertz radio system and other systems to handle the communication. And also the communication really comes down to either your communication site or your ED for calling in, because everybody's used to calling into the ED. And as soon as that gets overwhelmed, you're going to need to have somebody else take care of it. So finding the right spot for communication and the right people to take care of it is important. And then knowing who to call for help. As I said, a lot of the medical surge problem comes out of either infectious or in poison. And we have poison control in the state that is very active and can help out with poison exposures and give advice on who to watch for and what to do. Infectious, there are infectious disease experts available as well. So here are some of the medical red flags on dealing with a medical surge of patients. And the first one is poisoning. I touched on that briefly with both carbon monoxide and the train derailment. You have to be aware that children get a higher dose of poisons for many reasons. One is that they have faster respiratory rate, faster heart rate, so what goes in gets distributed much quicker than in an adult. And also they live closer to the ground, and the the airborne poisons are heavier than the air, so usually go down. So be aware that they can be higher, exposed at a higher level than adults. With pediatric patients also, they get better faster, but they deteriorate quicker. So you need to reassess and reassess and reassess, knowing that they can get better, but they might deteriorate right in front of your own eyes. And then also, medications for pediatric patients are all based on weight. So figure out how you're going to handle recording the weight. If you can weigh everyone when you come in, make sure you weigh them with kilograms and post it very distinctly on their chart. If you can't weigh them and need to know exactly what level to dose them at, use the Broslow or Hand-Tevi or any of those other tools on how to figure out weight. And also be aware that there are certain medications that aren't suitable for pediatrics, and you might have to give some of those medications either intramuscularly or intranasally instead of IV, because putting an IV in a squirming toddler may be difficult, and you want to quickly get through and treat the patient. So decon, again, with poisoning, these patients need to be deconned, and you need to be aware that, again, children are not the same as adults. First, you have to decide whether or not it's a dry decon versus wet. Dry decon can be used for many contaminations, but sometimes you do have to use the wet decon. And when you're doing it, try to keep the families together. The children will be much happier, and so will the parents, than dividing them up, kids this way, adults the other way. And also being aware that kids are really sensitive to temperature changes. So if you are doing wet decon, monitor the temperature, make sure it's not too cold, not too hot. And even in the summer, the children get cold quicker. So you need to make sure that they've got warm areas and blankets available to them as soon as they're decontaminated. And then finally, infectious. Well, we dealt with this a lot this past spring. Infectious seems to go very quickly with children, and the two areas that are most worrisome for them to keep them alive is blood glucose and oxygenation. At times you'll have a child who is very sedate and quiet, and you realize that the reason why they are so quiet is because their blood glucose is 20. So being able to assess the blood glucose, and especially in febrile infectious children, and treating it is very important. And then pulse oximeters are very important. Now, in a large volume of patients, you may not have enough pulse oxes. And so looking for other signs of hypoxia is wise. And then the other thing is, you're not going to have enough parents, or not going to have enough nurses to have with each patient. So make sure you have the family aware of what you're looking for. If the child's respiratory rate is increasing, and if they are, or if they're becoming somnolent because of hypoxia, give them the tools on how to tell you when they need more help. And then back to the previous one on medications and poisonings, medications and infectious are similar. We dose by weight, so weigh in kilograms, or use the tools to determine an area of weight. And then finally, certain antibiotics are not suitable for certain pediatric populations. And even Advil, ibuprofen, is not advised for children under 6 months of age. So be aware of what you've got. When you're trying to get a temperature down, as I said, IM, IN, and then also suppositories. Don't forget about your Tylenol suppositories. Oftentimes, if you can get the kids' temperature down, they look so much better, and they improve their circulation once they're cooler. So finally, kids are not little adults. We want to try to keep the families together when possible. You want to be able to track the patients. And then be aware of the special needs patients in the pediatric population. And these could be behavioral or psychosocial issues, like kids with ADHD or autism situations. Some kids are nonverbal and trying to figure out how to communicate and know what's going on, or even if they're too young to be verbal, say under a year, and you have an unaccompanied minor, you need to figure out ways to calm them and make them feel at home. And then also a lot of children are dependent on medical equipment like respirators, ventilators, oxygen. So always be aware of what's going on and if they happen to have information with them that's helping it. So that's about it for the pediatric surge talk. My contact information is at the top. As I said, Alex is going to talk about MDH and the final lecture this morning. And the Region 5 for kids, most of our stuff is posted in EMSC Improvement and Innovation Center. So that's the location for that. Rapham's location is there for their Peds Surge Workshop or workbook, and the Asper Tracy people. So any other questions? I'll look into the chat here. I've got a few minutes.
Yeah, thank you, Dr. Kocken. And also, if you have questions, if you can place them in the Q&A portion on Zoom here, we can then help facilitate those to the right panelist. So please feel free. We'd like to have this be a discussion and would like to help facilitate in any way. So thank you, Dr. Kocken, and we look forward to the next presenter, Dr. Dingeldein. We'll give it a minute here if you want to write some questions. Seeing no questions in the Q&A, I guess we'll move on with Dr. Dingeldein's presentation. Thank you.
No problem. Hi, everyone. My name's Mike Dingeldein. I am a pediatric surgeon based out of Cleveland at Rainbow Babies and Children's Hospital. Thank you for inviting me to speak today, and thank you. I think I'm the only non-Minnesotan on the panel. Thanks for having me virtually come to your state. So I serve a few different roles at Rainbow. Like I said, I'm a pediatric surgeon. I'm also the trauma director. And then nationwide, I'm involved in the same groups. So you keep hearing the acronyms today from some of these different groups that are here to help you prepare for kids and disasters. And that's what I do. For this Region 5 for kids, this Asper Disaster Center of Excellence Grant, I am the trauma domain lead for that. And there's another group that I think, another acronym you've heard, which is the EMSC EIC, which is part of the EMSC group, Innovation and Improvement Center. I run the trauma domain for that. Full disclosures, I do get funding from these various federal sources, including the one we're speaking about today, which is that Region 5 for Kids grant. You know, what are we talking about today? Well, as you can see, there's a theme to all the panelists, what they're speaking about. And our preparation today for the group of really talking about being able to handle a pediatric surge. The focus of my talk is a little bit more around the surgical surges, and the most common surgical surge would be something around a traumatic event. And how do you manage that? So objectives for today is talking about pediatric readiness in general, talk about some management strategies around pediatric surges, trauma surges, and then just talking about pediatric triage and how it's different, really relating also to to trauma. Purpose of all this is managing a pediatric trauma event in a critical access to rural community. So you'll also see one of the themes today, and I think probably all of us will say something similar, is that really the best way to prepare for taking care of a large surge of pediatric patients is to be able to prepare for a single pediatric patient, right? And that applies for both the medical and the trauma parts. That if your institution or your agency is prepared on a day-to-day basis to take care of a single pediatric trauma patient, you're going to be in a much better position when you're having to deal with that mass casualty incident, say a school bus rollover that involves multiple pediatric trauma patients. Why does this matter? Well, as we said before, pediatric patients, part of the population, 25% of the population is kids, huge number of kids. Also, the number one cause of morbidity and mortality in kids is trauma, right? It's the number one thing that kills kids. It's one of the number one things that causes a huge source of morbidity, including just in the US alone, somewhere around 50,000 kids are permanently disabled per year, mainly from traumatic brain injuries. Incredibly important topic. Why do we separate out pediatric trauma care? Well, we talk about this, but in kids, there are some true anatomic and physiologic and developmental differences, right? There's something different than that average day-to-day adult patient you're taking care of. So some limiting factors for pediatric kids, right? Or pediatric patients. Part of it, even though we're saying, US population, 25% kids, for many places, it's relatively rare to see a sick kid. In general, kids are really healthy and resilient. It's very different than, say, the geriatric population. There's, limiting factors, right? There's huge variation in pediatric requirements for nurses and physicians, especially training. Most EDs and most kids going to an ED or going to a general ED, not necessarily a pediatric specific ED, are seeing less than 15 pediatric patients per day. There's limited supplies of familiarity with pediatric equipment, supplies, medications. Critical procedures performed in less than 0.1% of pediatric patients. I mean, if you're taking all of the critical procedures that are happening in all the EDs across the country, very few of those are happening in kids. So people just don't feel comfortable doing some of those critical procedures that you need to do to care for a sick trauma patient, like decompressing their chest, getting good vascular access, giving blood. Physicians and general EDs, freestanding EDs, often perform no critical procedures each year in kids. We talked about some of the data already, but again, 80% of pediatric ED visits are to general EDs. EMS transport for critically ill children is a pretty rare event nationwide. Critically ill children are, again, relatively infrequent. Most EMS agencies, like greater than 80%, huge number, see less than 8 kids per month. We've talked about this hospital readiness, right? Part of this big push nationally over the last 20 years is saying that, again, if you're ready to care for a single patient that is ill, a single pediatric patient, then you're going to do much better. If you stick by some of these standards that we call the pediatric readiness for both hospital but also pre-hospital, that you will do much better. And the data bears this out, right? If you have an ED that has this pediatric readiness score that is high, you have a 4-fold lower rate of mortality for children critical illness that are coming to your facility. Being prepared matters. So, how do you prepare for a pediatric disaster event in your organization, right? Well, things just like, Dr. Kocken was talking about in kind of mentally preparing for a disaster or a surge of pediatric patients, you have to think about the same for trauma, just like you do medical. What is the nearest level 1 or 2 pediatric trauma center? How far? What are actually your transport capabilities? If it's in the same city as you and you're dealing with a high volume event, just like with the medical surgeons, most likely they're also dealing with that high volume event and they might not be able to take that kid immediately. If you're at a smaller community hospital in a rural setting where you have a relationship with that pediatric level 1, then maybe we'll be able to transport them quickly. But again, if it's a large number of patients, there's only so many helicopters and so many ambulances, right? You're going to have to be able to triage, you're going to have to be able to stabilize, you're going to have to be able to manage some of those patients in your institution while preparing to evacuate them out. How do you become prepared with no forewarning? It's great if you've got a 5 to 10 minute warning or even a half-hour warning of some event taking place. Most, unfortunately, don't happen that way. It's going to happen very quickly, and the warning that something is happening might be that people just start showing up, right? Or that they're just calling you. So how do you ensure competency for your staff? All of this goes down to being prepared. You got to have basic competencies. You got to know where the equipment is. You have to know the procedures for pediatric patients. This all comes down to this concept of pediatric readiness. We talk about medical, but it's really important for trauma patients too. This pediatric readiness concept as we'll get to in a minute, is again important and really important in trauma, because it's now recognized really by the American College of Surgeons in their newest standards for trauma centers that pediatric readiness matters. That means having thought about taking care of a kid ahead of time, knowing the infrastructure, the coordination, the equipment, and the policies around taking care of a kid. And if you just think about it ahead of time and you have people designating your organization to be able to do that, even if it's just one person, it really makes a big difference. The data shows this, and this is why now it's being, again, baked into national standards, including this is now not just for pediatric trauma centers, but all trauma centers have to be prepared to take care of a child. Again, why is this important? Just to take a step back and talk about the anatomy and physiology differences a little bit, and then how it relates especially to trauma, because there are differences, especially how you approach even the A, B's, and C's. So airway and breathing. How is this different? Talking about a small oral cavity, large tongue and tonsils, a really large occiput that's forcing that head forward that might be hard to then visualize when you're doing your laryngoscopy. The larynx itself is more cephalad anterior. All the cartilage structures in the face and in the neck, same with the cartilage structures everywhere in the body of a kid, right, are floppier, right? They just don't have that same rigidity to them. So that applies also to the epiglottis. It doesn't have that rigid shape to it. It's really floppy, it's U-shaped, and it's in your way. Hypoxemia is a big problem, right? Kids consume oxygen at a much higher rate for their body size than adults do, and they don't have the reserves of a large lungs relative to body size that adults do. So you have to be able to get them oxygen quickly. Head-wise is different. TBI is the leading cause of mortality. A large head with a thinner cranium relatively, and it's less protective, and that takes a significant force transmission, right? That head is really heavy. Why do so many infants come in with head injuries after they fall? It's because they're rotating with that weight down, and that head's going to take that energy impact. Circulation is different, kids. If you have a trauma patient that is really ill in front of you, most likely it's a bleeding. It's either neuro injury or bleeding. Bleeding, and especially hypovolemic shock, can be really challenging to recognize in a kid because the vital signs are a little bit different, because they haven't been smoking and drinking and not working out for 30 years. Their blood vessels work exactly like they're supposed to. That means that they're not going to be initially hypotensive, even with significant blood loss. They might be tachycardic. They might have other signs of poor perfusion, but that hypotension is the last episode. Or is the last thing that's going to happen before death. If you have a pediatric trauma patient coming into you that is hypotensive, that is a big problem. They are about to die. Vascular access, smaller structures can be challenging to get in, especially if you're in hypovolemic shock. It can be really challenging to get in a peripheral IV. How does this relate a little bit to disaster medicine? I think some of the other medical folks are talking about this today too, but when you think about it just from a respiratory standpoint, it's a higher minute ventilation, so we get actually increased exposure to inhaled agents. GI, again, you get dehydrated very quickly. Skin, body surface, ratios are very different for kids, right? They get cold really quickly. Their skin is thinner. It absorbs toxins much faster. Hypothermia is a major issue, not just for the medically ill kids, but for the trauma ill kids. All patients coming into a trauma bay end up getting cold. They're cold, the clothes are cut off to examine all body surface areas. You give them their cold fluids, IV. Same thing happens to kids, but even to a more extreme, you really have to pay attention and make sure you keep the kids warm. Big thing, which we'll, again, I think talk some of the other talks today, but developmentally, right? Their ability to escape dangerous environments is very limited compared to adults. And this is a really stressful, a kid coming into a hospital is a really stressful event for them, as it is for an adult, but really this impacts them developmentally and psychologically. So we talk about these anatomic and physiologic differences. What really is the difference when you think about the airway for a kid? These are probably my favorite kind of cartoon drawings of it, but it really shows that when you have a pediatric size airway, it's a funnel shape, right? It's not the straight cylinder. It's a funnel, meaning the narrowest point is actually below the cords. It's right below that cricoid cartilage. Things can get stuck in there really easily. You can't do the surgical airway procedures that you can do in an adult, like a cricothyroidotomy that you can do in an older teenager adult. You can't do that in a kid. The cricothyroid membrane space is very small. You can't visualize it, and you're just going to destroy their larynx. Emergency airways are a tracheostomy if you need to, or just that needle trach to be able to get some air in. What are the circulation differences? We talked about this already, but I just wanted to kind of hammer home the point that hemorrhagic shock can actually be very challenging to identify in a kid. You really have to think about what are their vital signs, what should be normal for that age. And if you're seeing changes in their perfusion, like with cap refill or mentation, even if you're not seeing hypotension, think still possibility that they're bleeding, especially with that tachycardia. You want to intervene early. What's that intervention? It's getting good vascular access, and it's replacing the volume and thinking about what you need to do for hemorrhage control, where you need to get them. Hemorrhage control, same basic principles apply, those same stop the bleed principles that I think all of you have probably learned for direct pressure and packing wounds. All of that applies to kids too. Tourniquets are okay for kids. What you need to do for the standard combat tourniquet that's adult size, obviously you can use for a teenager without a problem. You can even use that for an older elementary school age child, but trying to do that in an infant and a baby isn't going to work, right? You just don't, it's not going to fit. So think about even what you can use tourniquets like you'd use for placement of IV might be enough, or just basically squeezing around the extremity with your hand would be a great tourniquet. But same thing, tourniquets are okay to use if you need to. Vascular access, IO quickly, think about, in the hospital would be think about central lines. What's the volume replacement? 10 to 20 per kilo, ideally blood. If you're losing blood, you need to replace it with blood. Just filling someone with crystalloid isn't going to be helpful. So I know this is a busy slide with a lot of different aspects of it, but switching a little bit gears from the physiology and anatomy that's different in kids and how do you prepare for a trauma to actually making your institution prepared. Well, it's tackling all these points at the same time. And it means that you make sure if you have a disaster plan for your institution that actually going back and includes kids. And if you have a mass casualty incident plan, that it includes kids, right? That you and your group have knowledge of the pediatric equipment that includes the IO equipment, the vascular access equipment, supplies you need for hemorrhage control, right? Making sure that you have those basic trauma things for kids. Then you have a pediatric champion in your ED or your pre-hospital setting. That is probably the most important part of pediatric readiness, right? Again, designating someone to be in charge of making sure kids are thought of in all of your plans. Making sure you simulate it. Making sure everyone has policies and procedures, making sure that you're doing, training early on, and that you have good partnerships, right? That you know what your pediatric trauma centers are in your region, that you have contacts with them, that when you're doing these simulations or drills or putting together disaster plans, you're reaching out to them for their experts, or their expertise. So, practical considerations in a pediatric mass casualty, right? You're focusing really on the basics. You're talking about triage and primary survey. That primary survey aspect being the A, B's, and C's, right? That you're just trying to tackle the things that are killing them now, and that you're appropriately triaging. We talked about circulation at length, but it's the hemorrhage control of vascular access and replace blood with blood. Securing the airway, breathing, it's that right heart decompression. Remember, one of the things that can be killing a trauma patient is that right heart compression. What do we mean by that? It's that tension in the pneumothorax and that pericardial tamponade. How is that different from an adult and a kid? It really isn't. Other than for the younger you are, the more mobile all of your mediastinal structures are. They're really soft and floppy, and just a little bit of increased pressure can create, significant problems with the tension in the pneumothorax. Same thing just like with an adult or older kid, if you think you need to decompress their chest, just decompress their chest, same way as a kid as an adult. So we talked about this PEC role, but this pediatric champion, but again, making sure that you have that PEC role, but going and meeting who that PEC is and making sure that PEC is also considering trauma patients. So just as kind of the last topic, I want to talk a little bit about triage and field triage and how it's different, again, in MCI in a kid as opposed to an adult. This is kind of the standard start triage that you see for adults. And sorry, this isn't projecting well, but it's that being able to categorize people quickly based on their physiology into minor injuries, immediate threats, delayed threats, and deceased. And how do you do that with basic start triage? As well, if they're up and walking around, it's minor, you can move on. If there's no respirations after head tilt, you're not probably going to be able to save them. If they're breathing but unconscious, but they've got poor cap refill or increased respirations, some basic mental status, change it, that's immediate red, right? You need to assess them right away. Otherwise, you fall into that yellow category. So how is this different for kids? Well, you might have a scene that's mixed with kids and adults. It's the same basic principles. You're about airway and hemorrhage control and categorization and transport. But the difference for kids is you have some potential reversibility with that airway issue, right? And that's really the difference in some of the triage concepts. Some of the other triage concepts is that, calling them to walk away might not work, right? They might not, you're not going to expect a group of infants to be up and walking around and being able to use that to triage them. Don't assume they're going to follow commands from a stranger. You have to assume that some kids, and so older kids, might actually hide in the situation from the rescuers. If you now have a group of that green category kids, you have to think about setting up a supervisor, right? It's not the same as adults. You have to think about what are you going to do with those kids? Think about if you have some older teenagers that can watch them. If you have some of the other green categorized adults that can watch them, that'd be great, but you have to set up a supervisor. Think about some delayed presentation in kids, and then think about family unit preservation, right? You're trying to keep these families together, and you also really want to be able to make sure you're able to try and identify kids afterwards. So, Jumpstart is this is just an example of one of the triage mechanisms that's used for kids. This is for kids less than 8 years old, right? This is if they look like a kid, you use it. Kids are more airway dependent, right? They're very vulnerable to death by airway obstruction. One of the things it uses is peripheral pulse instead of cap refill, just because of their dynamic vascular system. They clamp down, you might not have the cap refill, but you'll have a pulse. Again, you can't use the simple commands. Big difference. What's the big difference between that? What we're seeing with that start category is that you get an extra breath opportunity before you declare them into that black category of deceased. So where does this fit in, right? Spontaneous breathing, no. You position the airway. If they give me spontaneous breathing on their own, great, get in that red category. If they have a pulse, no expectant, but you have the opportunity here to get 5 rescue breaths, different than what you're doing with an adult. With a kid, give those rescue breaths. And if they start spontaneously breathing, then you can move them to that red category, and you don't have to do the unfortunate thing of being in the category of not expecting them to survive. This is the same slide I showed you a little bit ago, but again, it's thinking about what you need to do to be prepared for pediatric trauma surge. Right at the end of my time here, happy to answer questions later or now in the chat. If you need anything, feel free to reach out to me personally, but also there's a lot of great projects nationwide. The Region 5 for Kids that we've talked about, the EIC, the National Pediatric Readiness Project, or reaching out to your pediatric trauma centers in your region. They'd be happy to help. Great. Thanks, everyone. Thanks for allowing me to speak today.
Thank you so much. That was an excellent talk. I really appreciate you joining us today. So thank you, Dr. Dingeldein. Is there any questions at this time? I don't see any in the Q&A portion, but we really do invite you to ask any questions to our panelists. We have such a wealth of information here. We want to make sure we're addressing your thoughts, concerns. We'll give it a minute here. Otherwise, next up, I think, is we have like a 5-minute break. So if you need to run, grab some more caffeine or use the restroom or whatever you need to do, we'll give you those 5 minutes, and then we'll come back, and I think it's Dr. Chahla that'll be up next. So thank you all again for being here, and we will be back with you in 5 minutes. And please don't stop the questions. So like in the next 5 minutes, if you have anything, please type it in the Q&A. I think all of our panelists are able to be here throughout the whole session. So if you miss the opportunity, after Dr. Kocken or later you have a question, please, we will facilitate those questions at any time we see them come through.
My name is Saydi Chahla. I am a pediatric emergency medicine physician at Children's Minnesota, working at Minneapolis Children's as well as St. Paul Children's Hospital. And the point of this presentation, after I get through the disclaimers and confidentiality, is to kind of go through some critical care management of children. The first case that we'll review is going to be trauma stabilization. I think that there has been kind of a great historic event in a small town in Minnesota where there's a car versus a school bus in the winter. And this kind of strikes at a few important points with respect to pediatric trauma stabilization. First, in this particular case, among others, where it could be like a school bus versus car, there'll be multiple children and few adults that obviously creates a lot of anxiety. And then there's both exposure injuries from trauma and environmental injuries. So first, we do want to make sure there's a safe scene to evaluate the patient. So it'd be helpful if there's a warm triage area. And then as you move forward, you prepare your triage zones. And then know your resources and know your limitations so you can get help. So then my first case is a head injury patient. When we talk about head injuries, there's often head lacerations, which can be confusing for open skull fractures. And in this type of particular case, there may be a lot of headaches and some with lacerations. So when evaluating the patient, you always want to go through the ABCs and make sure to take a deep breath with them. It'll calm you, help you focus on the patient. And then, they have an open airway. Then kind of evaluate their bleeding and their wounds. Can they follow instructions? Good signs if they're fighting you, if they're walking, that's purposeful movement. If they're screaming, they have words and they're talking. And that's how you're going to get through your GCS and continue to triage appropriately. When we're talking about head injuries, you do want to do ABCs, consider your C-spine, especially with that distracting scalp laceration. And then talking about how to control bleeding with head wounds, skin versus skull, kind of seeing what's exposed, and then trying to identify the bogginess that could occur with a broken skull fracture or a compressed skull fracture where you might find a dent in the head. As previously discussed, traumatic brain injury is the #1 cause of death and disability among children. So this is an opportunity for us to really make important impact on these traumas. So going to our first case, you have a 5-year-old child who is a kindergartner who's moaning, has irregular breathing and not following instructions. The patient has an elevated blood pressure for age, kind of approaching adults of 130/80, heart rate in the 80s, and and breath sounds of about 20. You have good oxygenation as they're maintaining their airway, but you do see that there's bleeding coming from the right ear with bruising and swelling to the skull. What do you want to do? And sometimes it's fun to have people chime in, and I have no problem if people want to pop in to the chat as we kind of go through these cases. So this is an immediate care patient. It would be ideal to transfer them expeditiously. GCS is concerning in less than 8, consider intubate. This may be a situation where there's low resources. And since this patient can decompensate quickly, we want to make sure that intubation doesn't delay transfer. But if you can get IV access and prepped materials, that would be ideal. And we're talking about intubation. There's calculations based on different tools. The one that I typically use is just a cuffed ET tube with 3.5 plus age over 4. And, you know, I honestly don't do math when there's a high stress situation. I have a card that has all the ages and it has this math done out for me. So all I have to do is just look at the age of the kid, find the cuff, and that might be a resource that might be helpful for you. For this age kid, it's a laryngoscope Max versus Miller. Size 2, you can use either, whatever's available, and you will have better success with video laryngoscopy, just because there's others who can help you with your positioning. So thinking about those resources and what you have on site. With significant trauma and maybe facial injuries, it may be easier to use an LMA or just bag the kid until you get them to where they need to be. So it's important to monitor the blood pressure of these patients closely. You can have elevated blood pressures with head injuries in the setting of like what's known as the Cushing's triad, where we talk about high blood pressure. The significant blood loss that can happen with head injuries in children is one of the biggest reasons that you can have death in these situations. So having 2 peripheral IVs and transferring them to a trauma center with critical care is the next big step. So our next cases are going to be regarding pediatric cardiac arrest. Those usually occur from respiratory compromise. And then this is kind of the H's and T's that are often associated with pediatric cardiac arrest. So you have blood loss with hypovolemia, oxygen deprivation with hypoxemia, acidosis from buildup of acid with poor circulation, and then with infection. You can have hypoglycemia that can lead to cardiac arrest, tension pneumothorax, tamponade, toxins, and then very unlikely is thrombosis. So with our first cardiac arrest patient, we think about a kid who is at a birthday party and they have a known heart history where they've had a surgery and then a pacemaker was placed. They're jumping in the trampoline and then they start looking sweaty, they sit down, become unresponsive, and 911's called. You know, this is a situation where this is one patient who needs a lot of attention as they're apneic, pulseless, and you just need to control the situation and get your head right. So what do you do when there's no blood pressure, lots of people around you? Just go through your PALS. So start rescue breathing, start your CPR, and assess the rhythm. So here's your rhythm. And anyone can chime in if they know what that is. So based on this pulseless VFib versus VTAG, you can start your CPR and then shock and reassess every 2 minutes. In this particular patient, the kid's pacemaker failed. There was successful return of spontaneous circulation or ROSC on scene, but there was poor blood pressure, and so they remained unresponsive. This kid needed respiratory support and they were intubated on scene. They did get a normal saline bolus to help with their hypotension. They had their blood sugar checked to make sure there wasn't additional things that were contributing to their cardiac arrest. And then they were transferred to a CBIC, a pediatric critical care center that had a CBICU so that they could get external pacing and eventually the pacemaker replaced. But these are situations that demonstrate how frontline workers really have an amazing impact, because this kid got what they needed, they got to their pediatric critical care center quickly, and then they returned to school the next week because their pacemaker could be replaced. They had enough expeditious care that they were able to get back into their routine. So here is another pediatric case where there's an EMS call from a mom who has their 4-month-old baby found unresponsive after co-sleeping. When you arrive, this 4-month-old is blue, limp, apneic, pulseless. And so what do you want to do? you are going to do your ABCs and then start compressions and support the rescue breathing, give oxygen, and assess the rhythm. So here you have no pulse and some inorganized electrical activity of the heart. So this is pulseless electrical activity. CPR will continue, and then you're just going to give epi every 3 to 5 minutes. Kind of going through epi for this patient. At this age, IV access may be difficult. You can use your ET tube, you can use your IO, and so consider what resources you have. And this particular patient had return of spontaneous circulation at home after an IO was placed and 2 rounds of epi were given. They were intubated in the emergency department because bag breaths were given en route. And head imaging was done because of some concerns for an unresponsive baby, considering for non-accidental trauma. That showed ischemic changes, which is like low blood flow changes, but ultimately the child did really well. And this is another example of effective care by our frontline workers. So just kind of going through cardiac arrest summary, you do want to focus on respiratory support with kids. So giving oxygen, give effective breaths. Consider assessing the rhythm when you don't have one. And you're shocking for your VFib and pulseless ventricular activity. CPR after shock. You want to get right back on those compressions and reassess every 2 minutes. CPR is going to continue to be the cornerstone for asystole as well as pulseless electrical activity, but then you also want to do epi every 3 to 5 minutes to help restart that heart. And then just kind of talking about our last croup, our last respiratory patient. Croup will be a focus as it's so common and we're entering into respiratory viral season. Croup is caused by upper airway swelling, usually from a virus. I know that coronavirus has been associated with quite a bit of croup, and then you can have it with influenza, rhinovirus, hemopneumococcal, but other things that might cause the upper airway swelling and changes consistent with croup could be a foreign body. And when you have a pediatric patient, that is something we have to consider when you have persistence of stridor. You're more likely to choke with the URI, and so that may be something to be considering if you have a kid who's eating a meal, has a history of upper respiratory symptoms, and then just being able to differentiate stridor and not wheeze. So stridor is when you have the high pitch whistle from the turbulent airway in your upper airway, and then wheezing is going to be during the expiratory phase when you have kind of obstruction from oxygen flow in the lungs. So there you go. So your treatment for stridor and for croup is going to be racemic epinephrine as a nebulized treatment, supplement to oxygen for those who are hypoxemic, and then Heliox. The use of Heliox is pretty much at a more critical care center, as it's not something mostly available at other institutions. It kind of helps with the turbulent airflow, and it's not really helpful in patients who have oxygen needs over 40% FiO2, but it is a nice supplement to use when you're waiting for your steroids to kick in, which is also something that can be helpful. But the steroids are going to be something you can give by mouth or intramuscularly if the patient's not able to take by mouth safely. And then if you just have like a barky cough and no stridor, you can consider cold air to help with constriction of inflamed blood vessels in the upper airway or humidified air. The last thing to talk about is wheezing and asthma, as we also see quite a bit of this now, as well as in the setting of respiratory viral season. The poor air quality has made this really an issue throughout summer as well as winter. So talking about the cause of wheezing, you have inflammation, mucus production that causes the prolonged expiratory phase and the stacking of breaths where they can't move air out. These lungs are hyperinflated. You're going to see kids who are working hard to breathe with supraclavicular, intercostal, and abdominal accessory muscle use. The treatment and cornerstone of care is going to be albuterol en route. The use of steroids and Decadron can help to decrease the inflammation. And then en route, there is magnesium you can give through IV, but also ketamine is a nice adjunct to a kid who you're feeling is decompensating to a point where you may want to be giving bag breaths or intubation, because that can help with relaxing the upper, relaxing the muscles in the lungs to help open up the lungs until you get to a critical care center that would be able to help you with the critical asthmatic patient. So with that, I guess I can wrap up, but if you have any questions, you're welcome to email me or ask through the chat.
Thank you, Dr. Chahla. That was great. We do want to invite time for any questions to Dr. Chahla. Dr. Chahla, do you have any thoughts as we go into respiratory season about the, RSV, which is obviously a very big pediatric infection we face every winter? Any thoughts of suggestions for our EMS providers or hospital providers that aren't at a children's center?
Yeah, I think that we are going to see a lot of people who need suctioning with RSV. And I think that should be one of your first interventions, particularly in the setting of children under 1, where they don't have like the effective cough or ability to clear their airway. So, doing suctioning nasally as well as orally, and then if need be, start on supplemental oxygen. Blow-by is not able to concentrate your FiO2 as well. And so I know the kid might not like it, but if you want to help them with recruiting alveoli, just having like a mask or a nasal cannula would be helpful as well. And then I think when we're talking about critical patients, we always want to think about people who could be most significantly impacted by RSV. And when you have children under 6 months, they need frequent suctioning. Their alveoli and their upper airways can be obstructed by the mucus production of RSV so quickly. And so suctioning can be life-saving. And if they are to a point where their secretions are too much or they're getting tired from breathing, those are the babies that become apneic. They stop breathing and they need rescue breaths, and they need transfer to a place where they can potentially have continued respiratory support, whether it be intubation, high flow, or CPAP. But en route suctioning is going to be critical. And then kind of understanding where the baby is. Those babies don't feed very well when they have poor air movement, and so they are more prone to being hypoglycemic, and that might be something to consider in these patients. Just like if you're thinking of infection, you do want to go through your ABCs in a critical patient and consider if they need fluids as well as dextrose support.
Yeah, thank you. I just, we're facing the impending probable RSV surge again, so I appreciate you giving some thoughts to that. And I know too, just to put a plug out there, Children's does have access to providers for clinical guidelines. And we just recently, not me, but others within the institution developed high flow nasal cannula guidelines that are kind of weight based. So something to maybe check out as we're heading into, respiratory season and the potential for, seeing a potential surge again in all of these respiratory infections in our pediatric population. So thank you again, Dr. Chahla. Any other questions? We're a little ahead of schedule, so we have time and would really like to answer questions and facilitate conversation. I know it's hard when we're virtual because you can't just pop on and ask it, but have to type it in. But we do value knowing what we can do to support you. And we'll give it another minute here because, again, we have a little extra time. Quiet group today. We want to know where you guys are at, so let us know. Otherwise, we'll keep things going.
Good
All right.
morning, everybody.
Thanks, Alex. Yep, I'll step off here.
Yeah, sorry, I was like, where did my unmute button go, since Zoom likes to change things? So hopefully everyone can see my screen. I'm just going to go over a couple of resources that MDH has, like Paula already briefly covered for you in depth. So we do have an objective just to make sure that you guys have increased awareness of all of the resources we have available on the MDH website specific to pediatric surge. And I do believe we have 2 poll questions. So Chelsea, I'm assuming you are doing those. We could do our first poll question. So our first question is, we just want to know if folks are aware of MDH's Pediatric Surge website. Yes, no, you're not sure. We'll just give you a couple minutes, or maybe not a couple minutes, a couple seconds to answer. And then Chelsea, we can share the results when you are ready. I can't see the result. Oh, there they go. Okay. Cool. So we have about a 50-50 split of folks, which is not totally surprising to us. So that's okay. And then I believe we have a second question. Yep. So our second question is probably going to be a little more tuned into those roughly 50% of you who said you were aware. So we're wondering if any of you have actually used the resources on the Pediatric Surge website. Yes, no, or unsure. Chelsea, whenever you're ready. And there we go. Okay. So hopefully after this very brief presentation, folks will be more aware of what we've got up there, and you'll be able to utilize our materials in the future. So I do have a recorded video for you, just walking us through the website. And so someone let me know if audio is not great.
Good morning, everyone, and thank you for coming today. My name is Alex Waterman. I am the Medical Surge Coordinator for the state of Minnesota, working on all types of medical surge. I work in conjunction with Marley Etchinson, who's organized this event with our partners at EMSC today. Thank you for being here. I'm just going to take a couple minutes and run through some of the resources that have been developed over the years and updated for pediatric surge events. So to start, this is the Minnesota Department of Health homepage. It was revamped a little bit ago. There's a couple ways you can get to our pediatric specific items. So you can come down here to our search bar, I am searching for, and you can write pediatrics. I can spell. I'm just going to say pediatric surge. And when you search, it is the first thing that comes up. The other way you can get to everything is, coming to our menu. Now, everything is still in the same place, just again, our homepage looks a little different. So in our drop-down menu, you can come to healthy communities, environment, and workplaces. Again, this is actually the same page, so it should look the same. And when you scroll down, you get to emergency preparedness and response. Click on that. And this is our emergency preparedness and response homepage. I do highly recommend that folks bookmark this page because it has a lot of useful information for preparedness, planning, response, exercising on a lot of different topics. So if we scroll down, we do have a medical surge section, and you can access the materials again in one of two ways. The first way is by clicking on medical surge. It will take you to our medical surge education and planning homepage. These are just listed in alphabetical order. Pediatric Surge Project is here at the bottom. The other way, of course, is to come straight through and click directly on the project. By doing that, it will take you to our Pediatric Surge homepage. So on this page, we have a lot of information. So we try to organize it in a very simple way. We really wanted to make this page functional and useful for those responders and those planning for these types of events. So the work group did a really great job in 2019, pre-COVID, to really revamp a lot of these materials to make them more useful. Our purpose of our toolkit is to prepare individuals, healthcare facilities, regional healthcare coalitions to respond to incidents involving pediatric patients and a surge of pediatric patients. We do have a very short 4-minute overview video on YouTube. It takes you through absolutely everything in this toolkit, which is great. It's a fantastic little thing. If you have time to please watch. We do have some quick links here for those folks who don't love to scroll through materials. We have everything broken down into assessment tools, planning tools and templates, education and training tools, exercise tools and templates, and then response tools. So if you are coming to look for an exercise you want to do at your facility, you can simply click and it will drop you down the page. We are going to go to the top though, and I'm going to take us through a few things. So starting with assessment tools, as you can see, again, to meet that goal of kind of functionality, we've done a lot of stuff to help folks. So if you've never talked about pediatric preparedness at your facility, or you want to start to have a more in-depth conversation about it, we have some checklists, both the regional levels for coalitions, facilities for healthcare facilities, clinics, anything you name it. And it will run you through, these are the things to start thinking about. We also have a PowerPoint that I'm going to open. And you can obviously download this file. But we have a PowerPoint that does help you go through to have these conversations at your facilities. Gonna just pop back. To go along with that PowerPoint, we created a facilitator's guide. So if we open that, here we go. This is in PDF form, but it basically just says, this is what this PowerPoint is, the intended audience. It's 19 slides. It will take 60 to 90 minutes to talk about this at your facility. And here's some stuff you should do, maybe before holding this conversation. And then to make this really useful for folks, we actually created presentation notes. We tried to divvy it up so things in italics is kind of like instructions, like you can take this PowerPoint, add your name, add any facility logos, things like that. And then we wrote a script. So folks who maybe have never, facilitated this type of conversation before, you have the tools to really do that. Obviously, everything is modifiable because it is a PowerPoint. So you can add things, you can change things. You don't have to use this script, but again, our goal was to really make things useful for folks. So we've done that with a lot of, oh, that jumped me down the page. Sorry. We've done that with a lot of our tools. If we keep going, we've got planning tools and templates. The pediatric primer has been around for a long time. It was a very hefty document prior to us updating it in early 2019. So if you look at this now, it's much shorter. It's about 23 pages. That's because we didn't get rid of information. We did streamline it, and we did pull out a lot of the appendices that were embedded in this primer to, again, make it more useful and easier for folks to grab the pieces that they need. So one of those things was like the sample menu. We just have that listed on its own. Any template we do try to put into Word just to make it very simple for folks. So again, if you open a template saying, yep, we need a plan, you can just, oh, sorry, I'd have to download the file to demonstrate. But when you download the file, you just have click and tap to enter text. And if you tab through those, it will give you a box above, giving you very explicit descriptions of what you should be entering in there. So again, hopefully making this very, very simple for folks to use. As we move to education and training tools, our pediatric surge videos are really incredible. We put a lot of information in these videos. The work group, our pediatric surge work group, worked really, really hard on these. And so there's 6 modules. When you click on this link, they do have their own landing page. We have six modules. It tells you exactly what each module is going to cover. It will tell you the length of the module. So some of them are pretty short, 8 minutes, great. And then we also included all the PowerPoints that go along with these modules, just to make sure we were meeting accessibility standards. Those PowerPoints include the scripts. When you click on each module, it will take us to, I'm going to just pause. It will take you to, pausing, there we go. It will take you to MDH's YouTube page, and it will play. There are captions, but again, we just wanted to make sure people were able to access things, which is why we also posted the PowerPoints. We also have training scenarios, a facility training matrix for folks, and then we move into exercise tools and templates. So if you really want to do an exercise, which we really do encourage folks to exercise things, you can do tabletop exercises. As you can see, we have a situation manual for you. Here, we've got slides that would go with the tabletop exercise, talk through. Again, we created a facilitator's guide for that PowerPoint. We've got victim cards if you want to go bigger. These were created by the Ohio Hospital Association, and they're quite good. And then the Illinois Department of Public Health has a great resource that they created with their EMSC program. I thought about doing this in Minnesota, and then we found this resource and went, let's not recreate the wheel. So we do link directly to that, and when they update it, we'll be sure to include the updated material here as well. Moving further down, we have response tools. So if we need a quick reference on how to stabilize and transfer pediatric patients, Again, let's just open that and take a peek because it's a great card. You can print this out. You can pull it up on your computer screen if you're charting, and it will really help you go through the steps of, do I need to get this child to a higher level of care, and or what do I need to do for this child right now? I love this card. If we have if you need to open a pediatric safe area, again, details about what is a pediatric safe area are in the primer, but we did try to pull these out just so in the course of an event, if you needed things quickly, you didn't have to open the primer, which I think used to be over 50 pages, and find these materials. They're right here for you. But if you want to learn more about what this is and what are we talking about, then you can find that information in the pediatric primer. We also include links to our behavioral health homepage. Just open that page and show you. We do have a dedicated page. It has a lot of information on here. And again, you can see quick links. So we've got child and school resources, disaster planning, suicide prevention, and teens. You can jump down that page and see what do we need to help children, floods, coloring books. And I'm going to get back to these. We also link directly under additional resources. We have a lot of different resources from kind of external partnerships. So HHS, has a great resource for pediatric healthcare leaders and clinicians. It's a fairly new, kind of came out in COVID times. AAP, obviously, we link directly to that. Asper Tracy is a great resource for all sorts of topics related to preparedness and response, and they have a topic collection specific to pediatric and children. And the other thing I really love is MyCPAS. So we're going to go here. If you haven't heard of MyCPAS, it's a really great resource. It was designed by teens for teens here in Minnesota. The Minneapolis Youth Congress, specifically the 2015-2016 cohort, created this. PAS is the Spanish word for peace, and so that's where they came up with the name. So MYC is the Minneapolis Youth Congress, and then PAS is peace. So this resource is just a teen guide to mental well-being. I believe they were also trying to make an app, but it's just a great resource, peer-to-peer resources for teens, which I love, and it was Minnesota made. So in a nutshell, that is our website. We are always looking to keep this material updated, revamp it. There's a lot of information on here that is really, really useful. So if you are perusing and you see something that you think would be a great addition, we really want this website to be a go-to place if something were to happen and you need some quick information. A lot of energy and effort and subject matter expertise goes into these projects, and we want our colleagues across the state to use them. So if you have ideas, feel free to email us. And the last slide will have that email address. With that, I'm going to stop this recording and we can do questions.
Whoops, I went one too far. So that is a really brief overview of the materials on the website. Here is our kind of generic emergency preparedness and response email at the Department of Health. So if you guys ever would like to add materials, or you think something needs to be updated, or you think of something that would be useful, please, by all means, shoot us an email. We are more than willing to update things or add things to the website. Again, I know I really stressed this in that recording I did earlier this week, but we really want to make this functional and useful and usable to folks. So I'm going to stop sharing and I will turn it back to Chelsea.
Or me.
Sorry, I was like, never is gonna take over.
We're one and the same sometimes. So, sorry, my lighting is looking a little off here. I apologize. I look kind of like an Oompa Loompa, but great talk. Thank you very much, Alex. I'm going to open it up to all of our panelists here that were part of today, because we do want to take this opportunity again to allow you to ask questions again if you have any specific ones. Otherwise, we've been kind of trying to come up with some questions too to just kind of help facilitate ongoing conversations. So I guess I'd be curious, like, I'll open up to our group that's on here. Like, obviously in today's time, there's a lot of staffing shortages, and that's put a lot of strain on all parts of emergency medical services, from, you know, the field to the hospital. Do you guys have any thoughts or anything that's been working at your institutions to try to help with that, especially as we're moving into another respiratory season? This is one that I think we're all asking the questions of, and I don't know if anybody has an exact answer for, but just something we can maybe think of together. And if anybody has comments listening that you found helpful, please put those in the chat and we can share that with the group. It wouldn't be able to be visualized necessarily, but we could make that known too.
Yeah, so this is Paula from Minnesota, and I know during the original surge from COVID, for the adult COVID, that a lot of the pediatric beds in adult ICUs in hospitals that had both pediatric and adult ICUs were converted into adult beds because they needed the ICU's volume. So one of the things is to try to incorporate the pediatrics back into those mixed ICUs and try to have that available. I know the group in I want to say Oregon have been working hard at that and trying to figure out what you can use as a tipping point to decide when you want to switch things over. And so I know they've been talking about that and trying to make sure that their RTs are able to handle both pediatric airways as well as adult airways. I was wondering, Mike, if in Ohio, if you guys have talked about how to handle things if you have another pediatric surge and are lacking the space.
From the medical side, sorry, I don't know. I can tell you from my hats of kind of trauma and ECMO, we're always concerned about space. I mean, what we're seeing was impacting us, last year with kind of that triple surge that we're seeing was then our inability to do basic elective, even some emergent OR cases. So that all the ICUs were full. This is really impacting hospital operations, and we're working as a region and as children's hospitals throughout Ohio saying, okay, where can we potentially shift kids to that need kind of urgent level cases? And then even looking to see what the regional ECMO resources are, because we're starting to, test and strain some of that resource also for the really sick respiratory kids.
Right, and also in our region, we did set up phone calls between the major centers, especially during the triple pandemic. I don't know, Alex, you were involved in that, right?
Yeah. So since most of you guys are Minnesota based, I'm sure a lot of you may or may not recall what we called the C4, and that came out of COVID, and it really started as a way to find adults med surge or initially ICU beds for COVID patients. And it evolved a lot throughout the response, right? So then it was, we're not really seeking ICU beds, we're really seeking a lot of med surge beds with like a specialty component at a hospital. Critical access hospitals needed to get someone, to a GI specialist type situation, or a cardiac specialist. And then in the last fall, we weren't seeing a huge uptick in adult cases, but RSV hit us, and it hit us hard, as I'm sure you all know. And so we had a pediatric C4, which essentially was a conference call between or among all of the hospitals. Children's led it Dr. Maslanka, and I'm blanking on our other physician lead, unfortunately. And what we did was we really talked with a bunch of hospitals. So I know, okay, don't quote me on this because I'm totally going on memory, but I do believe it was Fairview, the U, who said, you know, we can take kids, we can put kids in adult beds, you know, in this age range. You know, and so that kind of increased their ability to take peds. And, you know, they kind of worked in the reverse. In, you know, the early stages of COVID, we used peds beds for adults. And last fall we saw like, yeah, we need more peds beds. So we did the flip-flop. We used adult beds for kids. And it worked pretty decently. You know, nothing is perfect. And we all know that there's a lot of staff burnout and we've lost a lot of help. And that's kind of our biggest limiting factor. And it takes time to train nurses and physicians and everything. So we're going to be running into staffing shortages for some time because of, you know, as a huge result of COVID. But, you know, we do have the ability easily. At the health department, we're kind of involved on the side. You know, if we start hearing from hospitals, hey, we need help, this is what we need, we do have the ability to reach out and get things going. We don't necessarily run things. The C4 for peds and the C4 for adults was initially started and kind of organized through our Metro Healthcare Coalition. And so they're the ones who really do the day-to-day operations of pulling folks together and setting up a system that works for all of the hospitals so that they can share information that is HIPAA compliant, you know, things like that. And here at MDH, we fund the coalition. So we're kind of involved on the side. You know, we're happy to do that funding aspect. It's really, really important. And I think we're going to see a bigger and bigger need for it as we move forward.
Right. And what happened with the C4 is that people got to know other people. So you knew that when you were calling one institution, you could, you know, if that person wasn't there, you could use their name and they go, oh, you really mean you're serious. And take the requests as they came and address them. I know Chris Gell of the Metro Coalition was instrumental in that. And I know they also reached out to Duluth and the Mayo and etc. They were all involved with it, trying to equalize and as load level, because at one point you'd have no room, at another point you would. So yeah, that was a very good thing for handling the surge.
Yeah, and Paula brings up a great you know, point that I think we hear on the emergency preparedness side of things all the time. It really boils down to relationships. I will cold call people saying, hey, this is who I am and this is what I need from you. The likelihood I'm going to get a more positive response is if I've already established a relationship with them, obviously. So again, I think it really does boil down in a lot of aspects to relationships. And I'd be more than happy to pick on some of our coalition leaders on this call if they would like to chime in on how relationships are important in the response world.
Sorry, this is Dr. Chahla. I think that when we're talking about surge and relationships, you also have to know what you're asking and from who. And so people have to be aware of how much high flow, how many like intubation beds, how many nurse beds they have. And so really understanding those resources from the top down, because in order to know what you have, you really have to start from the ground up. I mean, it's crazy how quickly an emergency department can fill up, how many patients can come in a short period of time, and just having the opportunity to have staff that is reevaluating the patients that you have so they don't decompensate, but also to look in their storage units or whatever and see, I only have a few more high flow setups, I only have a few more intubation setups, and then understanding how you can flex up and flex down for the surge component. So, you know, there's talking to people, and there's kind of looking around you and knowing what you have.
We ask about relationships, and that's key for everything we do, right? it's you really need to develop solid relationships and do it at a time when the surge isn't happening. So when you need help, you know who you're calling for, because obviously if someone's calling you for help, it's a lot easier to say yes to someone that you know. And also just you then have an understanding of you know, their institutions and what they need, and also on the flip side, you know, what we can offer. But we encourage, you know, every hospital in the region, you really should have a relationship with your pediatric trauma center. You should know who the program manager is. You should know who the trauma director is, so you can reach out when you need something.
Yeah, I have a question for Mike, which is always a thought in my mind. You know, we don't like to transfuse pediatric patients unless we need to, and outlying hospitals that may not have easy access to blood or such might get in a situation where they need to, but they don't want to pull the trigger, or they do. Or do you have some like an overall global advice for when you've got a child that's might be hypovolemic from blood loss, and what you would say? Definitely you transfuse, definitely you don't. How do you, or is it too much of a slippery slope?
I would say if you think you are hypovolemic from blood loss, which is if you're hypovolemic and you've had a trauma, it's from blood loss. So if you need to transfuse. And even if your institution, say, doesn't have a specific pediatric massive transfusion protocol, you oftentimes will at least have some emergency blood available, some sort of O negative. I think the most important thing, especially for little kids, is to be able to give that aliquot of blood and reassess, and not just reflexively giving 2 to 4 units of adult size O negative blood, that you're really thinking it in per kilos, and you're giving 10. I like to usually start, 10 per kilo, give that blood. Does the kid respond? Does the heart rate come down? Does the color look better? And does that buy you time to identify your hemorrhage sources, help get them under control, and get transport mobilized? And if it looks like that you're not a true responder, or you're just a transient responder to that blood, just making sure you have that blood available again and give it again, and trying to do something to get it warm. Even if you don't have a formal level 1 or Belmont or the pediatric sized rapid infusers, doing something, whatever you can, to get that blood warm when it's going in. And warming the room, warming the patients. It should be really uncomfortable for everyone in the room. It should be that warm. Yeah. Right.
No, thanks. I know people are reticent to give the blood, but when you need it and they're showing signs of hypovolemia, especially as you said, the heart rate being elevated, not just because the kid's crying and screaming. If the kid's crying and screaming, he probably doesn't need the blood. It's if the heart rate is higher than what it should be when the kid is not doing anything, that we would then go ahead and give the blood.
And those sources of where you can lose enough blood to make you hypotensive, just like an adult, it's in the chest, it's in the abdomen, it's in the retroperitoneum or down the pelvis. But also in kids, you can lose a significant amount of blood into the head, especially a baby, a significant amount of blood into the head, to even make yourself hypotensive. A really large epidural where they have fontanelles where the head can expand. There's a lot of blood in there. Even some of the really big like subgaleal bleeds will have significant blood loss into that.
Yep. Thanks.
So we did get a question come into the chat, so I'm just going to read it out loud and then we can discuss. The question is, are there any suggestions from the presenters on how to engage our hospitals better? Sometimes we are met with a "we will package and ship," and that's a difficult barrier to work through. Materials from this group have helped, but we can only pass along that information. So, and I will just add, this is from a coalition perspective. So I'll start, and then I'm going to hand it off to our docs and EMSC to see what their ideas are. I think from the hospital preparedness program viewpoints, this is why part of this, barrier is why ASPR now requires clinical advisors in each coalition, and they have continued to refine what that role is. And if you read, in depth about it, one of the core responsibilities of that role is to engage other clinicians throughout the region. So I know we've struggled with that because they introduced that role, and then COVID, as every project that was going on, COVID is was the excuse that just had everything kind of fall apart. We get that. But I think moving forward, really developing those clinical advisors with the limited time they have to step into that role to better engage all clinicians, it would be helpful. Chelsea, I don't know if EMSC has an idea on how to better engage hospitals, or
Chelsea's in the background of me and saying no at this point. So work to be done, I guess, right? Well, I think we're getting close to time, so we can maybe do our wrap up, and then I do have some slides that I want to share about how to acquire your credits. Thank you all to our speakers and panelists here and everyone who could join. It's been a great morning, so thank you all. So give me 1 second here, because I'm not always the most technically savvy. Hiding right behind my, there we go. Okay, so again, thank you all for joining today. This is a QR code that we really need everyone to fill out. That is the survey for today's presentation. I'm going to go through a few slides, so the timing on each of these slides might not be fast enough for you to click on the QR code and finish all of them. So we are planning to send these QR codes out in an additional email today. So please look for that. In order to get your continuing education units, you do have about 2 days to get this completed. So again, I'll emphasize 2 days to get this completed. So please make sure you look for that email with those QR codes if you're not able to scan them as fast as we go through them here. So this is for nursing. Again, this is nursing continuing education comments or for hours. It does look like they are requesting that you put your first and last name in the chat. So I would suggest you do that at this point, basically kind of a roll call that you were here and made it to the end of the talk. This QR code will then link you to getting your continuing education. And again, you do have a finite time of when you need to complete this by, so please be aware of that. And then there is a contact there for Robin Goodman if you do have any specific questions or concerns. And again, this QR code for nursing continuing education will be sent out. This one is for EMS. Again, this is EMS providers. This is the QR code. It is actually the same as for the survey. So we don't necessarily have another QR code you need to fill out, but you also do need to send an email to Chelsea here at EMSC to make sure that she's aware that you want to apply for these credits, and she will then send you your certificate. So this again will be sent out to you, but please make sure you get this done within 2 days as well. For physicians, again, this is for physicians only, and thank you again, Dr. Dingeldein, for your presentation. If you are interested in getting a CME credit for participation, this is the steps you'll need to take. You have 3 days, but I would aim for 2 because you just never know. So you need to register, and then you'll get a code by Case Western University. This says it here. So this is the QR code if you're a physician. So you'll scan that, but you do need to create an account beforehand. And if you're having any issues, please reach out regarding that. So again, thank you all for joining today. I appreciate all the panelists and the time that went into organizing this conference on pediatric surge. I think it was extremely beneficial, and I hope everyone found something that you learned or could take back to your institution to improve pediatric care and readiness, both in non-trauma and trauma patients. If you do have any questions or concerns, please reach out to us at any time. And again, please look for the email with the following QR codes that you can fill out and get your respective continuing education units. Any last remarks from any of our panelists or anyone else? I haven't been able to look at the chat recently if there's any other questions. Yeah, Alex.
We do have one question. So Chelsea, I'm probably gonna kick this one to you because we have a question about, can we claim credits for 2 different disciplines? We have someone who's both an RN and a paramedic. I do not know the answer to that.
I don't think Chelsea offhand knows the answer to that either. We can try to look into that and get back to you on that one. It's a good question, but I'm not sure how that would work. So we'll have to look into that.
Carolyn, why don't you shoot us an email? You can email me and I can just forward it along. That's not a problem.
Thank you.
I'll put it in the chat if I can find the chat again. There it is.
Any other questions that we're seeing or other comments? Oh, we're going to go back to the survey here in case you guys need that. Wonderful. Well, thank you all again. We'll give you a couple minutes back to your day, not too many, but thank you. Have a wonderful, safe weekend, and thank you for all for the work you do and the care you provide.
Thank you.
Thank you.